Welcome everybody. Very glad to see you. So today is our last session of the series on COVID for people with serious illnesses. And I'm Dr. Spandana. I'm a pediatric palliative care physician in Hyderabad. This ECO-series initiative of IAPC supported by Hyderabad Center for Palliative Care and Two Worlds Cancer Collaboration. And this is the 9th of the sessions, and we have covered many sessions including ethical dilemmas and moral challenges and pathophysiology, and also regarding what are the new updates happening about COVID-19 out there. So today's session is about sharing stories of COVID-19 experience. But just before we go into the sharing of these stories and their experiences, I just want to introduce you the team that has been working behind the scenes. You have been seeing me a lot because I introduce most of the facilitators, and Dr. Gayatri, today's facilitator, is one of the project lead. I just want to tell you that this has been a lot of teamwork, and as you can see from IAPC, we have Dr. Sushma Bhatnagar, Dr. Savita, and Ms. Nisha, and the rest of the team are Dr. Aruna, who is our adult palliative care fellow. Kamara is a pediatric nurse practitioner from Vancouver, and Chuck has been helping us from Vancouver, and he has been doing all the technical aspects. And Dr. Gayatri is one of our project leads, and she heads the program in Hyderabad. Dr. Megan Doherty is our pediatric program director, and she helps us with the pediatric palliative care program and a lot of the ECO series that we do from Hyderabad. Dr. Muhammad Ishaq, he is our pediatric palliative care fellow from Hyderabad. Dr. Natasha is a pediatric palliative care fellow, but she has also completed her HEMONC fellowship. And all the questions that you have been receiving, she has been compiling them. Dr. Nandini Valat, she is associated with National Cancer Grid in India, and she has been very instrumental with a lot of ideas we have been taking forward in this series. Mr. Prashant Pillai is from ECO India, and ECO India has supported us from the beginning, and we are very thankful for them to help us bring the series. And then there's me, and I'm a pediatric palliative care physician from Hyderabad. And Dr. Stuart Brown, he is based in New Zealand. He's part of Two Worlds Cancer Collaboration, and he has been a pillar of strength for us to take this forward. Mr. Swaroop Imaraju is our nurse from Hyderabad, who helps us lead the program currently. And Vinila is our MNJ coordinator. She helps with the program, and she's the one who is coordinating a lot behind the scenes, sending the emails. So I just want to say thank you, everyone. And it has gone this smoothly because every one of you has done such a wonderful job. So thank you. And can we stop sharing slides? In the meanwhile, I just want to remind you, please keep yourself muted if you do not have to speak. And if you have any questions, just keep posting them in chat, and we will reply to them as much as possible in today's session. If not, we shall send the answers in the email. And also, I'm going to hand it over to Dr. Gayatri, and she's going to facilitate today's session. Thank you.
Thank you very much, Spandana. And thank you all the participants for joining. So with great pleasure, I introduce the first speaker, Dr. Eric L. Cocker. He's the Director, Global Palliative Care Program Division of Palliative Care and Geriatrics, Massachusetts General Hospital. He's also Associate Professor of Medicine and of Global Health and Social Medicine, Harvard Medical School. He's honorary chair, Department of Palliative Care, University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. Senior Health and Policy Advisor for Palliative Care Partners in Health, Boston, USA. Most important what I know about him is that because he's so well known for his international work and for the work he's doing in Vietnam, he also happens to be my mentor in one of those early days of training in leadership in palliative care. I welcome Eric, and over to you, Eric.
Thank you, Dr. Palat. for that very kind introduction, and delighted and honored to be with you and to speak with colleagues throughout India. As you know, the epidemic of COVID-19 hit quite hard here in the US. And I hope what I've prepared is what was requested, but in any case, if it's not exactly right, I'm happy to also have questions. Now, can I advance the slides, or do I just say next slide?
You just say next slide. We are
Okay. So in this slide, I just want to point out two things. One, this is an older patient, and in the US, so many of the patients that I took care of at the height of what we call the surge, when our hospital was filled with COVID-19 patients, were older people from what we call nursing homes, places where older people stay when their families can't take care of them. Um, because of the crowded conditions and the lack of personal protective equipment for the patients and the staff, the epidemic was devastating for older people, one after the other dying. And also, this patient, you only see one person in this picture. Isolation and loneliness and more severe mental health problems related to isolation and social distancing are very common, unfortunately. Next slide, please. This is just to say I don't take any money from drug companies. Next slide, please. So in the next few minutes, I'll speak a little bit about infection control and personal protective equipment, then a bit about symptom relief, and then a bit about psychosocial suffering and relief. Next slide, please. So I hope that India will do a better job than we did in the US protecting our highest risk people from getting infected with the virus. And the high risk groups include people living in poverty or in very crowded conditions, like those in nursing homes, prisons, military barracks, or just very poor neighborhoods where people are packed together and live very close to each other with many people in one room or one house. Also, people who are immunocompromised because they have other chronic illnesses, because they have cancer, because they have AIDS, any kind of immunocompromise. Healthcare workers, of course, are at risk, but also sanitation workers, people who clean hospitals and clean buildings and keep our streets and our buildings clean, and food service workers, everyone from the people who sell food in the market or in supermarkets or in cafeterias are at high risk. And then, of course, family caregivers of infected patients. For them, the minimum that needs to be available are surgical masks, hand sanitizer, ideally with high percentage of either ethyl alcohol or isopropyl alcohol, and some sort of sanitizer to clean surfaces. And then, of course, social distancing is important. There are detailed guidelines. I suspect they exist in India for how much alcohol, for example, should be in hand sanitizer, and maybe about what kind of about mask design. But I will also give some websites where those details are available. Next slide, please. When taking care of an infected or a possibly infected person, there the personal protective equipment is much greater, much more things are needed. There should be hand hygiene before and after the contact to help prevent transmission. If possible, the masks that block not only droplets. Yeah, it's fine to record, by the way, if you're recording this, it's fine. The surgical masks, okay, I'm getting a question about how much alcohol is required. The US CDC, as I recall, has recommended for ethyl alcohol, they recommend a percentage of 62% in a hand sanitizer. For isopropyl alcohol, they recommend, I believe, 70%. That's my recollection, but I don't think I don't think the data are very good on this. These are more data from what percentage of alcohol tends to kill most bacteria and viruses. When taking care of people who are possibly infected, it's ideal to use a mask that not only blocks droplets, but also blocks aerosol. And those are what we call in the US N95 masks, or in the European Union, they're called FFP2 masks. And they need to fit properly. People with big nose like me, it's hard to get a good fit. So it's recommended to do a seal check or a fit test. Also goggles or a face shield to prevent virus getting in through the eye, again for aerosol. And this is especially important when intubating a patient or extubating a patient, and we don't recommend using nebulizer treatments because of the risk of aerosolization. There should be a gown with long sleeves used as a single use and disposed of, or used only for one patient. Single use gloves. Minimize time in the room and minimize proximity. For people who do palliative care, this is anathema to what we're used to. We want to spend time with patients. We want to touch them, hold their hand, be close to them. In this case, it's really better to minimize time in the room and minimize proximity. And if possible, use smartphones or other screens to be in contact as much as possible. Next slide, please. The main medical needs, the pulmonary care, I won't go into very much, other than to say that obviously oxygen is important, because the main complication is infection of the lungs with adult respiratory distress syndrome and hypoxia. Oxygen is very important. We don't recommend non-invasive ventilatory support with CPAP or BiPAP because, again, the risk of aerosolization. So critical care is very important. In palliative care, the main symptom is dyspnea, as well as psychosocial distress. And the two pictures are at the bottom from the Ebola epidemic, showing how much bereavement there is in the community. Is a mask with valve more useful or not? We don't use masks with, I'm sorry, there's a question about masks with valves. The masks with valves we call a non-rebreather mask. Non-rebreather masks, which have a reservoir and a valve, provide the highest possible fraction of inspired oxygen of any mask, any simple mask. So yes, a non-rebreather mask or a valve mask provides the higher fraction of inspired oxygen, for example, than just a plain face mask or a nasal cannula. So if it's available and the patient is hypoxic, yes, that's a good thing to use. Next slide.
Dr. Eric, we don't have to take the questions in between, just not to disturb your flow. We'll have time to take them at the end, like after your presentation. Yeah, thank you.
Okay, thank you. So what I struggle with all over the world is, and I hope this isn't the case in India, but I suspect it may be, as it is in so many countries and even here in the US. It's not well understood that opioids not only relieve pain, they're wonderful to relieve dyspnea. They shouldn't be used if dyspnea can be relieved by treating the underlying problem. But for patients who are dying of COVID-19 and pneumonia, or who do not have access to ventilatory support, opioids can relieve the suffering, and in the right dose, you can prevent patients from suffering from dyspnea. The risk of significant respiratory depression is very low if guidelines are followed. And here are some basic guidelines. The first is that for treating dyspnea in an opioid-naive patient, I typically, dyspnea that's refractory to treatment of the underlying cause, I typically start with a dose of morphine that is half of the usual starting dose for pain. So for example, for intravenous morphine, instead of 2 milligrams, I typically start with 1 milligram. Or if I'm doing it orally, maybe 2 or 3 milligrams rather than 5 of oral morphine. Of course, if there's somebody who's dyspneic, I prefer to give IV because the response is so much faster. The patient will feel relief. If the dose is adequate, the relief will occur within 10 or 15 minutes, whereas an oral dose may not take effect for 45 to 60 minutes. If there's no relief after the first dose, again, if I give it IV after 10 or 15 minutes, if it hasn't worked, it's not enough. I give another dose, and if that hasn't worked after 10 or 15 minutes, then I double it. And with COVID-19, often respiratory distress becomes very severe very quickly. Patients who were maybe sick for days and had a little bit of shortness of breath, very suddenly, whether at home or in the hospital, they sometimes become very short of breath, and it takes repeated doses and doubling the dose and even doubling it again to relieve the dyspnea. So the good news is, though, that it takes effect if it's given IV within 10 or 15 minutes. So you can very quickly find the right dose. If the dyspnea is severe or constant or if frequent doses are needed, then it can be scheduled, given every 4 hours orally or IV, and a rescue dose added in the typical fashion, around 10% of the total daily dose. And once the adequate relief is achieved, then you can also give a sustained release oral version if it's available, or injections or oral doses every 4 hours, or a continuous infusion. Next slide. Other symptoms of COVID, the COVID virus can infect many different organs. The autopsies are finding it in many organs, including heart. And we see a lot of patients with elevated troponins when they're admitted. That may be because of infection of the heart, but also with severe COVID-19 pneumonia, it creates pulmonary hypertension, which puts a lot of strain on the right heart, which also could be a reason for release of troponin. Kidneys, it affects kidneys, and it tends to cause or predispose patients to renal failure. It affects brain, it gets into the central nervous system, and we have a lot of patients who get delirium and sometimes agitation. And then, of course, in the blood, there's a lot of thrombosis, deep vein thrombosis, large vessels, small vessels, even on the arterial side. So it can affect many different organs. If the dyspnea is maybe partially due to COPD or asthma, of course, treat the COPD or asthma aggressively. If they may have pulmonary edema from heart failure, you can diurese, but again, be careful to be gentle with kidneys in COVID-19 patients. And for delirium with agitation, there's all the usual non-pharmacologic interventions, reorientation, keeping them in a quiet place. Try to avoid benzodiazepines, especially in older people, because it too often causes paradoxical agitation. Haloperidol is first-line treatment for medical treatment for agitated delirium. Next slide.
Dr. Eric, we have 2 more minutes.
Okay, yeah, almost there. Psychosocial support, very difficult for patients and families to be separated. So smartphone communication is ideal. Having social workers or volunteers or spiritual supporters stay in touch via smartphone, both with patient or family, and then treat anxiety or depression. Next slide. Anxiety in patients who are dyspneic most of the time, the anxiety is due to dyspnea. If you treat the dyspnea by treating the underlying cause or by giving opioid, the anxiety resolves. So please, if patients are dyspneic and anxious, treat the dyspnea, and you often don't have to treat the anxiety because it goes away. But again, if it's a problem, haloperidol is first line. Be careful about benzodiazepines in older people. If the anxiety is really persistent, a selective serotonin reuptake inhibitor like fluoxetine or sertraline or citalopram. And for depression, of course, also a selective serotonin reuptake inhibitor. Next slide. I'll finish with this. These are two guides that can be helpful. One of them just appeared today from WHO. Unfortunately, the palliative care section is not very detailed. I helped them write it, but it went through lots of editing, and it ended up not being very long or detailed. Much more detail. That's the one on the left, the orange one. A lot more detail in the pink one on integrating palliative care into responses to humanitarian crises, both available online. The last several slides simply show the essential package of palliative care as it appears in the WHO guide to integrating palliative care into humanitarian crises. And I'll stop there. You can just scroll through the last slides. That's the list of medicines, the list of social supports that are needed for people living in extreme poverty. Yeah, and I don't know what's next. Yeah, that's all. Take care of yourselves. You need to protect yourself as you're taking care of others, and take care of yourselves. It's very hard to watch so many people dying. I hope that doesn't happen in India, but it's happening in a lot of places, in a lot of countries, and it's painful to watch. So resilience is important. Take care of yourselves. Thanks.
Thank you, Eric. Vinila, can you hold on to that slide? I think it will be very useful to look at that essential things which are required for palliative care, last two slides. Vinila, if you can just help us going back to, yeah, before that. The two slides, one more before that. Yeah, so useful to, can you tell us a little more about these two slides?
Well, this was generic. This was for, this actually comes originally from the Lancet Commission on Palliative Care, where I led a group to design an essential package of palliative care that should be available to everyone, everywhere, and should be affordable to make available to everyone, everywhere, including medicines, equipment, and social supports. In this slide, it shows equipment. And although this wasn't designed specifically for COVID, there's a couple of important points here. One is that patients are often sick for a long time, and it's important to prevent pressure ulcers because, well, sometimes patients are in the ICU on a ventilator for weeks even. So anything to reduce pressure on pressure points. Nasogastric and feeding tubes, both for drainage and for feeding, are very important. Opioid lockbox needs to be in every clinic and hospital so that the opioids can be kept safe. Those were just a few comments. Adult diapers is very important, especially to reduce burden for caregivers or for patients at home. The previous slide again shows the list of essential medicines. These are all safe, effective, inexpensive, and readily available in most places in the world on the market. And I put the red markers to show some of the ones that I talked about. Morphine, at least immediate release oral morphine and injectable morphine, haloperidol for agitation and anxiety, and a selective serotonin reuptake inhibitor for more serious anxiety or for depression.
Thank you, Eric. That was very useful and practical aspect of understanding COVID. I see one question in the chat about morphine and midazolam usage.
How do I go to chat and look? Okay.
So the question is about, can we use morphine and midazolam?
Sure. Yes. I mean, well, it depends for what purpose. So midazolam is a short-acting benzodiazepine, rapid onset, short duration of action. But sure. So, for example, for patients in the ICU, we who are on ventilators, we commonly use the two together. It would depend on the purpose. Oh, I see. With morphine, midazolam may be used or not. Sure, it can be used. There may be a bit more respiratory depression, but depending on the situation, we use the two together. There's not a drug interaction that's deleterious other than a little bit of added respiratory depression.
Thank you, Eric.
Then,
any more questions? We can take one or two questions.
There's a question about diazepam versus short-acting benzodiazepine. The reason we use diazepam is just because it tends to be the most readily available one. Very short-acting benzodiazepines like alprazolam, again, there's so many benzodiazepines, I don't know which ones are available in India. Alprazolam is a very short-acting one that we have in the US, which is not good because it tends to cause a rebound anxiety. So the very short-acting ones may be not ideal, but other benzodiazepines are fine. Very useful.
So there are some comments. Dr. Seema is a psychiatrist, and she says citalopram and mirtazapine can be used for anxiety and depression. And
yes. Yes. So again, I just mentioned citalopram, sertraline, and fluoxetine. Escitalopram is fine. It sometimes is more expensive than other places, but India has great generic drug industry, so that's fine. And mirtazapine is also very good. Also can help with sleep, better given in night, and also tends to enhance appetite. So the mirtazapine is a very good drug.
And a couple of more comments. Anxiety, Dr. Rajeshri says, can be due to other factors, and benzodiazepines can be useful. And Dr. Stanley says very important point about subcutaneous route, very useful in our home care situation. So please comment on the use of this route in your critical care.
Yes, I'm so happy to hear that subcutaneous route is being used. It's just very odd that although it is used in hospices in the US, in hospitals, it's rarely used. But subcutaneous route is fine for morphine. It's fine for haloperidol. It's fine for benzodiazepine even. Subcutaneous route is fine. Even for continuous infusions, it can be used if the volume isn't too great. Thank you for mentioning that. And it's very easy to do. And the needle can remain in place as long as it doesn't look like there's infection. So yes, absolutely.
Thank you, Eric. I think, Eric, if you can just stay on, we'll just hear other speakers, hear from other speakers, and then we'll get back to you with more questions. Thank you, Eric. Wonderful presentation. So most of us, we are working as health workers, indirectly helping people with COVID. We are not involved with direct COVID patients as a frontline workers. So we really don't know what's happening inside. So it was very useful to hear from Eric about inside story. And now we have a very important speaker who's joining us today, Dr. Solomon S. Pudi. He's a specialty doctor in ENT at National Health Service, Oldham, United Kingdom. He is a survivor. I don't know what's the right word to use. He's recovering from COVID infection, and he has this experience which he very kindly agreed to share with us. So we are very eager to to hear from you, Dr. Solomon. Over to you.
Yeah. Hi. Hope you guys can hear me.
We can hear you very clearly.
Yeah, wonderful. Yeah, thank you for introducing me, and thanks for having me today. I just want to quickly let you guys know. So I'm on call tonight. So if I suddenly get a call in the middle of a meeting, I'm really sorry because it will be an emergency from the hospital. So I might have to answer a phone call. I'm apologizing in advance. I'm working as a clinical fellow and a specialty doctor here in ENT in Ashton-under-Lyne in Manchester. And I'm going to quickly talk to you guys about how I have got the infection, how I've gone through the infection, and what I felt through the infection. So back in February, when Italy was having a lot of cases, we were still in a stage where we had only just 1 or 2 cases in UK, and we had all these advertisements on TV and public safety measures, things on radio. We were being told that there are a lot of methods put into place, a lot of plans that have been put into place to make sure that we don't have a severe problem here in UK. And it was at this point of time, maybe about 2 weeks before I got the infection, my colleagues in anesthesia were talking to me about, actually we were all joking about, what is going to happen in the next 2 weeks. We are 2 weeks behind Italy at that point of time, and Italy had reached a situation where people were walking in through the door in emergency departments, and they had to triage and decide whether a person gets a ventilator or not. So the cutoff point at that point of time was, for them, if you're more than 60 years old, you don't get a ventilator. We are sorry, we don't have ventilators here. If you're less than 60 years old, yeah, we will find a ventilator for you. Just wait in a bed here somewhere. And when we heard that, we were worried. We were really worried about it. And doing a tracheostomy in a person who has coronavirus is it's an aerosol generating procedure. A lot of people are put at risk if you have to do a tracheostomy in a person. But if you need prolonged ventilation, if a person is on a ventilator, you have to do a tracheostomy at some point of time, and you have to connect them to the ventilator so that you can wean the person from the ventilator. So most of the ENT people will have to be involved along with the anesthesia people in taking care of these patients. And we were all having some plans in mind as to what we will do in the future. And we thought we will never reach that stage where a person will walk in and we will have to make a decision whether that person gets a ventilator or not. That's not a situation any of us will want to be in. So I have this one colleague who goes to London every weekend to do clinics there in London. And he comes back on the first day of the week, Monday to Friday, he works with us, and then he goes back to London on Saturday and Sunday to work there. So on one of these visits, when he came back, he was coughing, and we were all kind of making jokes that he probably has coronavirus, and we were all just pulling his leg. And he was also like, yeah, when I was coming back here to Manchester, I was on this train, and when I was coughing, people were looking at me. And yeah, even I was kind of joking about it. And we all thought it was a funny thing at that point of time. But there was a situation 2 weeks into working with him. So I was in very close proximity with him while working with him. So we are doing surgeries together. We are doing clinics together. And I did one surgery with him where he was not wearing a mask, but I was wearing a mask, but he was very close to me. We were both doing an ear surgery, both looking through a microscope. I was having my eyepiece here. He was having his eyepiece very close to me here. So like very close to each other. I was wearing a mask. He was not wearing a mask. And he coughed during the surgery. And it was like a 4 hour surgery. And 2 days later on a Friday, I start to have a cold. And by Monday, I have sinusitis. And because we are in ENT, we can pick up ENT related problems more easily. So when I went to work on a Monday, my clinical lead and this consultant, the person who is always coughing, both of them look at me and they say, Solomon, your eyes are bulging, they're protruding. Are you having a cold? I'm like, yes, I'm having a cold. Then they say, your sinusitis has progressed to orbital cellulitis. You should probably start taking some sort of antibiotic now. I'm like, oh yeah, okay, maybe something I should be doing. So I start taking antibiotics. And the box standard treatment for sinusitis anywhere, you take analgesia, you take an antibiotic, you take some decongestant, and you take saline nasal rinses, and that's it. So that was what I was doing. And I don't know if this is the right thing to say or not, but I feel the more I took ibuprofen, the more I took something like analgesia, the worse the symptoms I had. I'm not really sure, but this is what I felt. So on day 3 or day 4, I started to develop a fever. By day 5 or day 6, I was kind of having the worst fever of my life. So this is something I need to let you guys know. I've had mumps in 2015, and that was a very bad fever. I'm working with ENT patients, so I have a lot of children coming into clinic in India who are having mumps. So I got mumps from one of the patients, and that fever was really bad. A very, very long time ago in 2007, I had malaria. That fever was bad. And I think I can compare this fever to those two fevers. It's equally bad or maybe more worse than that. You will feel your body is extremely weak. And at some point when I started having breathlessness, that was the worst thing that could happen. So day 6, I went to the hospital. When I was in the hospital, after I finished my morning ward rounds, I have been seeing patients. And the rule here is you don't wear a mask unless the patient has some problem or you have some problem. And for every patient, you have to change the mask. That was the rule at that point of time. And I was seeing patients. I did not realize that my fever is something uncommon. I was thinking I was having sinusitis and I have a very bad infection, so I've developed a fever. But while I was in the hospital, when I started having breathlessness along with fever, and the fever was rapidly progressing, I suddenly felt, okay, something's not right. I went into a room, I locked myself in that room, and I slept on the floor in that room because I kind of had a weird doubt and a weird fear inside my mind that something's not right. And I woke up in the afternoon, and my consultant, who I was supposed to do the surgeries again with, the same person, I went to him and I spoke to him. See, I cannot do the surgery with you today afternoon because I feel like I have these very bad, weird symptoms. I feel something's happening. I wonder if I am having coronavirus. And then he smiles and he says that actually even he had very bad symptoms in the past 2 weeks, but he thought it was not a serious problem. He got over it within a period of a week or so. So he thought it's not an important thing to tell people. And when he said the same thing to me, I then suddenly realized, okay, maybe he had some infection which has passed on to me, and I'm taking antibiotics, but my fever is not going down. And I have to take 500 milligram paracetamol, 2 of those paracetamol. So 1 gram in the morning, 1 gram in the afternoon, 1 gram at night. And even with that, my fever is not getting controlled. So this is not normal. That's when some alarm bells went off. So I went back into the same room, locked myself in, and then I started doing a Google search on what the symptoms of coronavirus are. And you will find this very funny, but on the National Health Services website, the only information that you get, and this is where your Google search comes into play. So your Google search is biased with regard to what your country has in its websites. So when I search on Google regarding symptoms of coronavirus here in UK, the UK websites will pop up first. For a person in India, the Indian websites will pop up first. So when I searched here in UK, first website I've got is National Health Services, and it says if you have fever or if you have cold, if you have cough, then you might be having coronavirus. Then you have to contact somebody. Then you have to call a particular number, 111, and they will tell you what you have to do next. And I'm like, okay, I'm not having cough. I have fever. Maybe this is not coronavirus. And I went to sleep again. I woke up in the evening. I felt there's something wrong in my chest. I am not able to breathe normally, maybe. So I went home. And by the time I came home, I felt I did not feel right. I can just say I did not feel right. I passed out on my sofa, went into sleep, woke up around 7 o'clock or 8 o'clock in the night, and then realized I'm definitely having a breathing problem. And I want to tell you why I am saying that breathing problem is like a severe thing for me. I'm a very fit and healthy person. I'm going to substantiate why I say that. I have run a 10K in 72 minutes in the last 1 year, and I'm 34 years old. And I go to gym most days of the week. So if I'm a person who has that kind of a fitness, and if I don't smoke and if I don't drink alcohol, then why am I having such symptoms? Why am I having breathlessness? So that's like a serious thing for me. So I called up my consultant immediately and I told her, see, I'm having these weird symptoms. I'm having breathlessness. I don't think I should be coming to hospital tomorrow. Please find out if you can get me a coronavirus test. And at that point of time, coronavirus test was being offered only to people who were critical in the hospital with classic symptoms of fever and cough. I did not want to believe what the websites here said. So I went into Google again and I searched for papers that have been published in China. And it clearly said that a lot of people started to have breathlessness from day 3 or day 4, and about 30% of people or 40% of people had breathlessness. and it even gave a list of all the other symptoms that they had and what kind of treatments they went through and what helped and what did not help. And I'm like, okay, so if breathlessness is a serious problem and if it is associated with coronavirus, then why is it not on the websites in UK? Why is NHS not talking about it? Why are other people in the hospital not talking about it? And I'm like, okay, so if this is breathlessness along with all these other symptoms, then it's probably coronavirus. I should be more careful. And the good thing was, I was sleeping in a different room at that point of time. So my wife is in a different room. I'm in a different room. I'm having fever for like 3 days. So I told my wife, you sleep in a different room, I'll sleep in a different room. We continued the same way. The next day morning when I woke up, the breathlessness was much more worse. I remember the time from my internship where we had a lot of ascites cases and pleuritis cases in the hospital, and we insert these drains and we take out the ascitic fluid and we drain this pleural fluid, and it has a very weird smell. So when I had breathlessness, I kind of had a feeling like I was getting that smell on my breath. And when I had malaria and when I had some other problems, when I had an IV fluid, when I had an IV line on my hand, when the IV line ran very fast, you sometimes feel that you're feeling like there's some water in your chest. And that's because if the IV line runs too fast, you probably develop some sort of pulmonary edema. That's the kind of feeling I had at the point of time. I felt like there is water inside my lungs, a kind of feeling like you're drowning. And that's with the smell of that pleuritic ascitic fluid on your breath. And you feel like, this is not normal. There's something weird happening inside my chest right now. And did not know what to do. Took paracetamol again, went back to sleep, woke up the next day, started to have a diarrhea. And it kind of felt like a diarrhea you have with like sort of like an irritable bowel syndrome. Frankly to say, I felt like whatever meeting is coming out in the same way. It's not getting absorbed. By the next day, day 7, day 8, I felt like I was going weak because whatever meeting, it's not getting absorbed. It's this really weird sensation. Day 9, the breathlessness started to go down. Fever went down on day 8. And day 10, I felt like all the symptoms went away, but extreme weakness. And I'll not lie to you, when I had the breathlessness, the situation was so bad that I'm a very religious person. I pray a lot. I contacted all the people who I know who are in my prayer groups, and I asked all of them to pray for me. That was how bad the situation was. I wanted to let my colleagues know that I have developed symptoms because I work with a lot of nurses and my colleagues, and I have seen a lot of patients in the hospital during ward rounds. There are secretaries in the clinic that I speak to every day, and they have to know that I have developed symptoms, and I can't call everybody and speak to everybody. So I posted straight away on Facebook saying, I've developed some weird symptoms. I don't know what's happening to me. But I want everyone who I've met in the last 1 week to be extra careful. And I don't think people should be going to hospital for silly reasons right now. Stay away from hospital. And when my colleagues saw my posts on Facebook, all of them called me and asked me what is happening to me. And I told them, see, this is what's happening to me. That's when they finally went and pressurized the hospital to test the consultant who was constantly coughing in the hospital, who was working with me, and he tested positive. That's when they realized, okay, Solomon is also definitely positive. He's got the classic symptoms. Solomon, stay at home for 2 weeks. Don't come back to the hospital. And apparently 2 days after I developed symptoms, my colleague, the other lady who's also working with the same consultant, she also developed symptoms. She's also asked to stay at home for 2 weeks. My consultants and colleagues who are working with the same guy, all of them have been asked to self-isolate and go home for 1 week. And it was a tough time. It was like almost like the whole of Department of ENT shut down for like a week or so. And we started to go back to the hospital slowly. And each of us had different kinds of symptoms. One had more breathlessness, one had more diarrhea, one had more weakness later on. It was different for different people, but fear was a very common factor. We spoke to each other daily. We were like, are you doing well? Is your spouse doing well? Are your children doing well? What's happening to everybody? If you have a problem, you call me. If I have a problem, I'm going to call you. And there were these much younger colleagues that we had who had much milder symptoms and got better very easily. It was as if like they had like a magical power and they shook it off very easily. And the reason it has hit us so hard is because we were all thinking from the data that came out of China that only old people are affected, people with comorbidities are affected, younger people may not be affected. And even if they are affected, they will have a mild flu-like illness and they'll get out of it very easily. And that's what we heard from everybody. And we thought we will be we'll be very strong, will not be vulnerable, but it hit us really hard. And the worst thing was, I went back to work after 2 weeks, and 3 days after I went back to work, I started developing symptoms again. I don't know why. I got the same breathlessness, I got the same fever. I told my clinical lead, she said, go back home again for another 1 week. I stayed at home for 1 week more. Went back to work, started working again, another 20 days or 25 days or so. I was told not to operate the tracheostomies in COVID positive patients. I was put on non-COVID emergencies and telephone clinics. Telephone clinics are a thing now. We speak to most people, we don't meet them. Even if we see a patient, if we have to put a scope down, if we have to examine the oral cavity, we have to wear an FFP3 mask and examine the patients. Masks are a rare commodity, and the rules have changed now. We have to wear a mask for every patient. And one of my colleagues who's operating on the tracheostomy patients, he developed the symptoms second time, and he sits behind me in my office, maybe like 1 meter behind me. He developed symptoms again, and 3 days later, I developed symptoms again. And this time, UK was very well prepared. This is like about 3 weeks ago, 4 weeks ago. I was told to go get a test this time. My nose was swabbed. This is my perspective. As an ENT doctor, this is my perspective. The lady who's taken the swab, she's probably taken hundreds of swabs in the hospital for people working in the hospital. She's a specialist nurse. And I felt the swab did not reach my nasopharynx. She just growled around inside my nose. Maybe went till the middle turbinate, and it touched my septum, touched my lateral wall of nose, came back out, did not go till my nasopharynx. I did not want to complain. I just wanted to go home immediately. And my swab came out negative, and people at the hospital called me and said, even though your swab is negative, you still might be having the disease. If you feel you're doing well, then come back to the hospital. So this is what I have felt regarding subsequent times when I've developed the disease again. Every subsequent time, your symptoms are shorter, they are not as bad, and you'll get over them very easily. Now that you know how to deal with it, you'll deal with it better. And this is how I dealt with it. I did not take ibuprofen or diclofenac at all, even though I had very bad sinusitis subsequent times as well. But I took a lot of paracetamol. I ate a lot of fruits, too many fruits. Most of them were oranges and grapes and apples. And I just tried to keep eating more. Every time I had this same irritable bowel syndrome, every time I felt like I was losing more stuff from my body, I kept feeding myself more. I've gained weight, but that's my survival strategy. I survived. And I have no access to azithromycin, any fancy drugs, nothing at all. I don't have hydroxychloroquine, anything. I cannot go to a GP. The funny thing about this thing is, so when I developed the symptoms, when I called my clinical lead and I said, what do I do? She said, call this national helpline number, 111. This was on day 6 when I had the bad breathlessness. When I called 111, they said, we are going to send you a link on your phone. Please follow that link. So if you click on the link on your phone, it asks you questions. Have you traveled to any country in the last 14 days? No. Have you been in contact with a person who's had symptoms and has tested positive for coronavirus in the last 14 days? No. Do you have a fever? Yes. And the answer that it gives you in the end is your fever is probably flu or seasonal cold. Don't worry. Contact your GP. I was like, that's the worst kind of suggestion a person can give to you. This is not a good helpline. And I was really worried about it. So I called my clinical lead back and I told her, I don't think the link works. So the day after I developed these symptoms, UK stepped up from level 2 to level 3, stage 2 to stage 3. So even the 111 national helpline changed. And my clinical lead called me again in the evening around 9 o'clock and said, call them again. So I called the national helpline, and this is the state of affairs here in UK in NHS. I had to wait for 57 minutes for the phone to be answered. And when the phone was finally answered, there was a kind of a younger person. I'd call him a kid. A kid answered the phone and he asked me, sir, what symptoms do you have? I said, these are the symptoms I have. I have sinusitis. I had orbital cellulitis. I have taken amoxiclav. I did not have relief. I'm having breathlessness. I'm having the worst fever of my life, and it's not subsiding even with 1 gram paracetamol 3 times a day. And then he's like, sir, I think you have coronavirus. Please don't go out of your home. I'm calling you at 10 o'clock in the middle of the night, and I'm telling you that I have the symptoms of coronavirus. And the first thing that you can tell me is not to go out of my home. I'm sorry for my language. Are you stupid? What do you expect of me? I'm obviously not going to go out of home. I have breathlessness. tell me what I have to do. If I stop breathing, tell me how to save myself. And this guy did not have any clue as to what has to be done. He said, sir, please stay on the line. I'm going to speak to my colleagues and I'm going to get back to you. And I'm like, is this Vodafone helpline services? What is this guy talking about? Okay, this guy has no clue what he's doing about what he's doing. And then he comes back online and he says, sir, sorry for keeping you on the wait. A specialist health advisor will call you back in a little while. And I'm like, how long is little while? I'm sorry, sir, I don't know, but a person will call you in a little while. That's it. I did not have any help on the phone. And I told my clinical lead, see, this is what is happening. I don't know what I'm going to do. And I went back to sleep again. And this is the funny thing about me going to sleep. Every time I passed out, every time I went to sleep, I woke up in a prone position. I always woke up in a prone position. I don't know why, with stool coming out of my mouth and me not being able to breathe. And much later, after I went back to work, I have been told by my anesthesia colleagues that if you sleep in a supine position, your ventilation perfusion has a mismatch, so you don't get enough air. But if you are in a prone position, there is good ventilation perfusion, so you get more air. And that's how I understood, okay, so that's why I
Dr.
was passing out.
Solomon?
Yeah, so go on.
Sorry to interrupt.
Yeah.
For the past 5 minutes, I was trying to say we are out of time, but your story has been so, it has been so good that you're going from one point to the other so much.
Yeah.
Sorry for interrupting. Dr. Gayatri.
Yeah, go on.
Dr. Gayatri?
Yeah, sorry, Solomon. You please finish what you're saying, and then.
Yeah, so the specialist health advisor called me in the middle of the night at 1:30 and she said, if you have a situation where you're not able to breathe in sentences, if you're only able to speak in words, then call 999. The ambulance will come and take you to the hospital. But otherwise, stay at home. You don't have to do anything. You will recover. And that's the only kind of suggestion I got from anybody. And I'm like, I'm on my own. I have to deal with this on my own. I went back to prayer. I called my friends. I said, please pray for me. And I think in a way, prayer saved me. And I know some of you might not be religious, but it's probably a good time to get back to religion. Yeah, that's it. That's my story.
Thank you, Solomon. I know it must have been so difficult even to recollect those events and to share with us. I don't know, thank you very much. And this is the first time we are hearing such a real experience from someone who's surviving. I don't know. I'm sure there will be some questions, and there are a lot of responses from chat, all of addressed to you, Dr. Solomon. And want of time, I just move on to the next session. I'm sorry, abruptly moving on. We'll come back to you. So thank you, Dr. Solomon. So similar experience for someone who didn't get it, fortunately, but went through this harrowing experience of staying in quarantine. So I want to invite Dr. Sanghamitra Bora, the State Lead for Palliative Care, Assam Cancer Care Foundation. Just tell us what happened. Maybe Sanghamitra, if it's all right, just keep it short so that we'll have more time to ask questions. Over to you, Sanghamitra.
Yeah, good morning, everyone. Dr. Solomon, it was very nice hearing out your story, and I actually related many things, many experience that you had shared with us today. So I'll just keep it short because I started to work for Guwahati Medical College, and in the screening area, this is the college where, it's one of the colleges where the main COVID-19 hospital has been set up. And I started working as a volunteer for this college because my organization has a relationship, a kind of organization relationship with this college. One of the kiosks belonging to Assam Cancer Care Foundation has been converted into the main COVID screening area for this medical college, and that's how I came into the picture of volunteering. So I was a part of the screening team where I had to supervise the infection control in that particular area, as well as part of the training team where I had to give the PPE trainings and other trainings related to COVID-19 for all state recruits. I mean, the groups that have been recruited for taking care of all the aspects of COVID-19. So on this fateful day when I was in the screening area, supervising the doctors and the nurses about donning and doffing of the PPEs. One of these persons, he came to the area, and then he seemed to be very sick. Sat on a corner, and his wife was with him, and he was, they were all very, it seemed that they were very, very, they have having a difficult time standing for the registration and all. So I just, blame it on my palliative care training. I went to him and I started to counsel them that, you don't have to worry about anything. Please wait for some more time. I helped them through their process, their screening process, and then because of that particular thing, I think the wife was quite very comfortable with me and wanted to ask me so many other questions. And that was a kind of a flow that started. After 2 days, I came to know that that person has been, tested positive for COVID. And that was a kind of a blow to me, because I was directly in contact with that person. And I informed my authorities. As a protocol, they took my swabs and they asked me to observe for the next 7 days for any kind of symptoms. Interestingly, I didn't have any symptoms, but on the 9th day, I actually developed high fever and kind of, a dry kind of a cough, not cough exactly, but kind of a irritation. And I had to inform my authorities. At the same point of time, it was extremely difficult for me to, realize the fact that, I am perhaps slipping into the infection of COVID-19. Interestingly, I gathered up a lot of strength, and I was told that I'll be sent to the isolation ward because of the fact that I was in a direct contact with a positive patient, and they did not want to take any kind of a risk. I called up my husband. I told my husband that they need to go out. They have to shift base from my home to my parents' home, and they went off. I thought I had prepared well because I also had old parents at home, and I really didn't want to take a risk on that. In the isolation ward, I have to tell you this, it's a government accommodation. I was given a treatment about, being a doctor. I was kept in a separate doctor's duty room, which was not used. And I got some bit of good facility. But then the main ward where the isolated patients are kept, it was extremely filthy. I mean, this is the condition of the government hospitals that we have today. The government promises many things, but unfortunately, when it comes to the practical application, it is absolutely zero. I'm really sorry to say this. So that was a kind of experience that I had, and it was the doctors and the nurses and the ward boys and everybody was kind of they were having those PPEs all the time. They did not talk. They didn't, react to anything. They were it was difficult for me to even, communicate with them. They would come, they'd serve food, and then they would go off. They didn't even ask us what was happening to us, So all this non-communication, a silent kind of a ward where you are unable to express your feelings. I think that thing has gotten to me very badly. And till the time my test results were available, it was almost 36 to 48 hours. And I did not have food. I did not have enough of water. I could not talk to anybody over the phone because of the fact that I was perhaps slipping slowly into depression. And then, thankfully, my test results came. It was negative. And, another battle that began was that I did not I had to persuade my authorities that I don't want to go to the quarantine facilities of the government facility. The doctors are being definitely kept in a very good facility in a 5-star hotel. But then, staying in a 5-star hotel out of your home, I really didn't want to do that. So I went off. I told them, I persuaded them. One of these people from the office, he actually gave me a letter to sign that, you have to declare that nobody is going to be there with you at your home, and you're going to be alone, so that you don't pass on the infection to anybody else if there is a chance. And when you have any kind of a symptom, you're going to notify. So that was it. I came home, and the next struggle began when I found that I was in a huge house with all empty rooms. Of course, it was my own home, but then I didn't find my son. I didn't find my husband, my pet. It was so emotionally draining that I was totally devastated. I actually came to know. I mean, I realized how it could be like for a person to stay inside a jail with nobody to talk to. How much would you actually do Facebook, or how much would you do chatting? Everybody was like, I felt that somebody who's trying to call me and give me some kind of solace. I felt I was being pitied. So that was a very bad feeling. I think even if I had got some kind of disturbance inside the mind, it was been aggravated because of somebody calling me. So I did not know what kind of feeling it was. It a kind of a mixed feeling that I am being alone, so people are pitying me, or is it that they really want to help me out of this situation? And even if they want to help me, how would they help me? Anyway, I'm going to be quarantined for the 14 days. I'll be alone. I didn't want to cook. I didn't want to watch movies. I didn't want to talk to anybody. My parents and my husband and my son, they made it sure that they do a video conferencing every evening. It was a kind of a little bit of sugar in the bitter thing, but that really didn't make a difference, because I did not want to show my feelings to them unless they get depressed. And, oh my God, my daughter is alone, my wife is alone, and it was on lockdown. So I didn't want to go out of the complex also. Inside the complex also, I mean, I did not want to go out of my house because people had, given weird kind of looks. Oh, she's a health worker and she's been going to the hospital. Now, she's exposed. And so all these mixed feelings were extremely difficult to cope up. I don't know how, I really didn't find anything constructive in the whole process. I did sit and then, did some kind of meditations also, but that really didn't help. To be very honest, it's very easy to say, you go do yoga, you exercise, it's not possible. It's for me, it was really difficult. I used to sit in my drawing room for hours, and just a cup of tea perhaps. The whole day would go like that for several days, almost a week. I think I did something like that without doing anything productive. I thought, I'll get time to sit, reflect back, write some articles, but that really didn't happen. I think these are some things that I really went through. And perhaps after a phase, maybe when I realized that, okay, the fever is not going to come back, I started talking to my friends again, all over again. And ECO really helped me, because I was also, I attended 2 or 3 sessions here. And then I started diverting my mind. So here it was important. It's important for all of us to realize that the fear factor for any kind of infection, when you know that the repercussions and the consequences, how they would affect your life, that is the worst part. And professional help, it depends on whether that particular person wants it or not. I think that is very important, because we just cannot say that this person is quarantined, so let us help this person. The reception from that person has to be there. I think the door for me was closed. I couldn't let out my feelings to anybody. And when I started to let out, that was the point where I started receiving good signals. Once you are inside that bad phase, that kind of environment, you really feel hostile towards everything that is coming to you. So, in short, that is what I had gone through. I have overcome this. Maybe the constructive ideas that I had were all, drowned into that situation. And of course, it's a life-changing kind of experience that I have had. I would definitely again want to work as a frontline worker. But having said that, the learning points are that unless and until a person really wants your help, you are unable to get that through to that person, however good your intention is. And to help that person, do not hammer anything on that person, because I really felt when my friends started to call up every day, every morning, every evening, they wanted to help, I knew, but then I really didn't want to take that.
Thank you.
Yes, Dr. Gayatri, that's it.
Thank you, Dr. Samit. I can feel it what. Thank you for sharing such an intense feeling what you shared right now. And please, because of lack of time, I really can't wait here to take questions from you right now. Please, I request all of you to post your experiences or questions on the chat, and we'll keep chatting. So I quickly move on to the next speaker. So we heard from people who experienced the COVID or who experienced the quarantine part of it. Let's hear from a palliative care worker while all this was happening, how we were trying to help those people who are having other issues other than COVID, and this issue about making essential medications available. Specifically, when you talk about opioid medications, we were in a situation where all the patients were running out of opioid medications, and one team from Tata Memorial Hospital, how they worked extra mile to ensure that morphine was available to our patients. I introduced Dr. Anuja Damania, Assistant Professor, Department of Palliative Care, Tata Memorial Hospital. Dr. Anuja, can you just quickly tell us how did you manage to ensure that the morphine was available to all your patients? Dr. Anuja?
Yeah, hi everyone. This is Dr. Anuja. I'm from Tata Memorial Hospital. Can we go to the next slide, please? Okay, so I'm narrating a story of Mr. Om Prakash and his wife. This is not about COVID infection, but about problems that palliative care physicians and patients are facing due to effects of country's response to this infection and pandemic. So it's basically about effects of what happens to our patients when there is a countrywide lockdown. So Mr. Om Prakash, he had already had a very difficult time dealing with his cancer and cancer pain for a long time. We kind of tried to stabilize his pain, and finally he had some relief with opioids and he felt better. And when we spoke to him about his prognosis, he really wanted to spend some time with his family in Uttar Pradesh, which is a state which is far from where he actually was, that is in Mumbai. And so he was thousands of kilometers away from his family, and he wanted to go back to his family and celebrate the festival of Holi there, which was in around first or second week of March. So after getting bit better with his pain, he just left for Uttar Pradesh in first week of March to celebrate Holi with his family and be with them. And he had kind of planned to come back at the end of the month, but there was this nationwide lockdown which was announced in the almost third week of March. So he could not really come back. And we had given him a prescription for 1 month, because whatever plan he had made, he needed to be there and he needed to continue his analgesics. So he collected his analgesics and left for his village. And he had not imagined, or nobody had imagined about this crisis and lockdown coming our way. And he had kind of, we were hoping that he'll be okay. I was in touch with him. He was on methadone and morphine and gabapentin and paracetamol for his pain. Fairly doing okay. The wife was taking care of him well. And I got this call from his wife that, okay, my medication stock is kind of getting over. This was in last week of March. And he had his medication still almost, 10th of April. And I was like, okay, so can we go to the next slide, please? So the question was how to make opioids available to him now, because this is a kind of difficult situation. So he was in a small village in Uttar Pradesh, which was around, I think, some 90 kilometers from Lucknow. And Lucknow is a big city, and there are opioid dispensing centers in Lucknow, but not in his village. So he had to travel from his village to Lucknow. So that's what the solution was initially. And I told his wife, you might find a registered medical practitioner, get a prescription. I will speak to your registered medical practitioner, and maybe we can, get some opioids for you from there. And, can we go to the next slide? So when his wife called me back in first week of April, and she said that she had gone to a private hospital in Lucknow, but the doctors were not taking in new patients at all. And there was, some chemists. So he just said that he doesn't have any opioids available, and we need a prescription for that. So which is obvious. So I tried speaking to the doctors. The doctors were not willing to talk on phone. So this is kind of difficulties we always face. So I recommended her, maybe you can go to bigger medical college hospital, and maybe you can get it from there. So referred her to SGPGI. She went to SGPGI, she got morphine. He was on 20 milligram of morphine Q4H, that almost 120 milligram per day. But what he got from there was 10 milligram of morphine. So his wife kind of was very scared, that because initially she was on 10 milligram, he was on 10 milligram of morphine, but with no relief. So she was scared, and she got this stock, 9 strips, 90 days stock, and she was like, I'm going to give him probably lesser dose to save my pills, because I don't know till what time we are going to be here. So there was no methadone available. So he did not get methadone. He had to probably take a gap for methadone. And, so he was in pain, and she was very worried about him. He was very worried. I was constantly getting calls from her every alternate days. And, I was trying to help. His family physician would come in and give injection diclofenac and paracetamol SOS. So that is how we were coping. And then we tried to find out what we can do. So I reached out to Nandini ma'am, and I spoke to her that this is an issue, and what should we do about it. So we kind of, with the help of guidance, I went through this NDPS Act rules, that there are rules available wherein we can post medications from one city to another and send it via India Post. India Post had some offices which were working, and there's this list of offices which were working in the India Post website. So I got in touch with a family, and there were some relatives back in Mumbai here. So what we did was, I called one of his relatives to my clinic here, gave her a prescription for 1 month. We are not allowed to prescribe more than 1 month of medication. So gave her a prescription of 1 month, and we decided that we'll post the medications from Mumbai to his place, and fortunately the post office in his area was functional, and we got all the addresses in place. So I went through the requirements of NDPS Act. So it says that we have to send medications with proper prescription as per the recommendations of Indian Medical Council Act and NDPS Act. So we have to make a proper opioid prescription, and packaging of medications has to be done. So before packaging, what happens is, in the post office, they check what is there in the package, because these post services are on only for essential commodities. So there were medicines, and there were this opioids. So we had to give a letter for the post office head, stating our our NDPS registration number, and we are a proper source of dispensing opioids, and we are sending this patient's. I had to give a copy of this patient's current medical summary, and with all those documents in place, I spoke to the post office head, and packed this medications and sent it to post office. They opened the package, and the problem at the post office was that she went to the post office, which is around 20 odd minutes from here, and they said that, okay, now you have to repack this. So you repack this and bring. And she had nowhere to go, because post office doesn't provide packaging services. So she lives around she lives around 2 hours from here, so she could not go home, because till the time she comes back, the post office will be closed. So she came back to hospital. So we had to do repackaging in the hospital, and then give all other documents. So I spoke to post office head in in Mumbai. I spoke to post office head in the place where this person was, so that there is no problem there. And I before sending medications, I had a video conference with the patient and relative to ensure that he is really there. And so there are certain things that we have to be vigilant about, so that we prevent diversion of opioids, because as healthcare professionals, it's our responsibility. If we are prescribing, we need to know every detail about where this medicine is going to reach. So I was me and my social worker, both of us were in touch with the patient's relative. So even if I am not available, she was available for her. So so then we posted the medicines. He had to struggle with lower dose of medications for almost 10 days, but the struggle was really worth it, because it took around 9 or 10 days for the medicines to reach to his place. And fortunately, there was no problem during the transit. So I did not get a call back, because I had given my contact number on the packet of medicines, that if there is any problem, please contact back on this number, because this was done first time. So we were really worried whether this thing will work, because it's kind of scary, because if anything happens in between, it is my responsibility that I have prescribed opioids. So we had to take the risk, and it was really worth it, because the medications reached to him, and he was he was relieved of pain. So that is what our goal was, and it was achieved. So basic understanding of it's very important to understand what is there in the act, because everything is there, but only thing is that we are too scared to apply it to our practice, because of lot of other issues around opioids. And lockdown has kind of opened up new ways for us to look at things and make things possible. So I think it should be in systems, and it should come I think it should come to notice of administrators as well, that this can be done, and we should put our processes in place for opioids.
Thank you, Dr. Anuja. That was a very useful information. I hope you'll be able to share us some links, so that all of us, we know we can help our patients.
Yeah, I will.
So I come to the last part of it. I know we are all running out of time, but this is the most important, I think, part which we should conclude with. Dr. Puri mentioned about so much of lack of information on website about various aspects. Today, at least in India, I feel that if we need information about providing holistic care to COVID patients, we'll have some reference happening available on our website of Indian Association of Palliative Care. So over to you, Dr. Sushma, the President of Indian Association of Palliative Care, who's to come very soon going to come out with a position statement by our association. Over to you, Dr. Sushma.
Thank you, Gayatri. I will speak as a Indian Association of President of Indian Association of Palliative Care, and also simultaneously in March, when I was shocked when the responsibility was given to me to take care of a COVID center of All India Institute of Medical Sciences. So when the Gayatri, Nandini, Doctor, everybody told me that we should come out with the positive position statement, and around the 2 months back, Gayatri told me that we should start eco section for COVID patients, so that people will have idea. I think everything came together, and I believe that we did very well. In not only as an Indian Association of Palliative Care, but all over India, I can see that there is no dearth of information. People are getting good information. People are getting guidelines in place. So we just thought that as an Indian Association of Palliative Care members, we should come up with a position statement. And the next slide, please. So the purpose of this position statement will be to guide healthcare professionals caring for COVID patients, because many of us are caring for COVID patients. Many may not be caring, but first part is that they are caring for COVID patients. If they are caring for COVID patients, what should be the guideline in place? And the second part purpose was to provide palliative care input to the government decisions, because in government decision I cannot see that there is anything in India, especially, that there is anything related to palliative care, because they still believe that if there is a lot of things for non-COVID patients in palliative care. Government, there are good guidelines in place. There is the National Palliative Care Policy. But as far as COVID-19 is concerned, yesterday I received a call from my director that now this is a time that we should start introducing or integrating palliative care into the COVID care. So I just realized that when you will reach to the surge, or when you reach to the peak, and the people start dying without any this thing, and then they start realizing that yes, now this our efforts of we think that it's all reversible. It is not reversible, and then now we should start integrating palliative care principles in COVID-19 management also. So hopefully we will have health ministry guidelines towards palliative care also in COVID-19. So definitely this position statement will help, and we will the second part which I told, that we will give them that how to optimize palliative care services to response of COVID-19. And as the Anuja has said that how much struggle she had to give pain relief to a patient who was away from her in the different state. So we will give some kind of a guideline to support the ongoing provision of palliative care in India, because there are many people, almost whole of the country, there are good palliative care centers, but definitely I can see my own patients, they are getting ignored because of this pandemic. So how we can give a balance of COVID patients as well as non-COVID patients? Next slide, Skanda. So we have divided our response, we have prepared in the 6 areas, and I think that everything you will find in the details on the IAPC website, as well as on the next issue which we are coming. It is as a dedicated issue on the articles related to COVID-19 patients. So from all over India, we have called for articles, those who have done something with the COVID-19 patients, if there's kind of any research or any kind of experience with the COVID-19 patients. So this will be there in the next dedicated issue of Indian Journal of Palliative Care. And in that, there will be this position statement that providing palliative care for COVID-19 patients when they are critically sick. Because I can see this in my ICU, how helpless a critical care specialist when patient comes, you know, day before yesterday, our sanitary inspector was doing a lot of work in the hospital. He was just guiding everybody. He was the boss of all the sanitary people. Yesterday, he came to the day before yesterday, he came to the hospital with breathlessness. We took him to the ICU, and within 2 days, he died in ICU. So, how helpless critical care physicians are feeling when a COVID-19 patients are coming with severe kind of breathlessness. So, probably our first part of our position statement definitely will guide that what should be their management plan A, B, C in patients, those who are coming with critically sick, in stage of critically sick and severe breathlessness. Second response which we have prepared is for providing palliative care for cancer and chronic end-stage liver. So, you know, I have already told that whenever there is a pandemic, the people, those who are suffering since last many years with chronic debilitating conditions like cancer and other end-stage, in these days, a lot of people, those who are undergoing, those who were going under for dialysis, all of them are finding it so difficult. So all these patients suffer. So what should be the government strategy for those patients, those who are suffering with chronic end-stage organ failure? Now the third part, which is going to be very, very important, that how to provide palliative care for children. I think children always remain neglected, and but in COVID-19 era, I can see myself that they are really neglected. A lady who is delivering a child 1 day after she said she was positive, and her in-laws and husband told that we will take care of this child. You need not to be worried. And she was really suffering, and she was really feeling miserable that why my child is not here and why I cannot breastfeed my child. On the other hand, parents are, I have seen this also group in my hospital, that parents were positive and their 2-year-old boy, he was negative, but there was nobody to look after. So it was such a big ethical dilemma that we have to leave this 2-year boy who is negative to the positive parents. And what should be our guidelines in place, that how we can balance all these things? This will be taken care in there are many things which we have covered in all these areas. I will not go into the details because of the time, but we have covered everything which is required in cases of children, that how should be government should do and what should be the palliative care practitioner should follow. Then providing psychological, social and spiritual support. And I think when you will read our articles and other people's article, the people, those who have sent articles in the dedicated issue of COVID-19, and we have seen that how a patient learns there's such a problem of social issues, and how we should be, practice to handle COVID-19 patient, as well as those patients, those who are not getting early stages, not getting these things, all sorts of psychological problems are happening. So what should be our aim in all these patients? And then fifth part is to how to integrate home-based palliative care to the palliative care provided by the institute, and the patients who are dying at home, how we can handle and integrate all sorts of palliative care provided by institute, by the centers, by the NGOs, and patients those who are at home, how we can help them. This also, I think this, all these things example you will get in next dedicated issue of Indian Journal of Palliative Care, with an example, with an articles. I think it is such a fantastic time that we have come out with dedicated issue. We are coming out with a position statement with the research article in the same journal. So you will find it. And then finally, when we heard that there is a problem when a palliative care physician is going to see a patient, they start saying that there is no need to use PPE and of PPE. So how should be a balancing attitude? What should be the regulation to use PPE? Level 1, level 2, level 3. What should be the what should be the guidelines. This will be covered in this position statement. Last slide, next, Sanda. So most probably what we think that with the position statement, the proposed outcome will be, there will be clear guidance and understanding about the judicious resource allocation. We will provide way to integrate palliative care provision, hospital-based, home-based, nursing home-based, and telehealth services. How we can integrate and promote telehealth, because through telehealth we have realized, and this is our own experience, we can do a lot. We used to do with the telephone, but now in these days when there was a severe crisis, we have realized that we can even provide good end of life care. When a patient is dying, we can see them through video and we can guide the family members how they can handle their patient. These recommendations may be used to, and probably maybe may guide the policymakers and healthcare professionals to adopt the principles of palliative care and to improve quality of care provision to patient, those who are suffering with COVID-19 and those who are suffering, or those who are suffering already with chronic debilitating condition. This is our proposed outcome. So I have not purposely, I was planning to keep all the names, those who have worked hard for this position statement, but yesterday night I finished, I came very late and I finished these slides, and I was worried that I may miss somebody's name, so I have not put that slide purposely. Almost 25 people sat down together. They have made this guidelines for the country. Yesterday I have spoken to Professor Paul from Niti Aayog about Nandini's initiative, that she has made a letter for me that how we should provide and continue giving opioids those who are on follow through teleconsultation, and he was very encouraging, and he has already set up a committee, and this committee will look into it, and definitely we will be having better teleconsultation as far as analgesics are concerned, which are very important for, especially for cancer pain patient. In the same sitting yesterday, again I talked to him in the evening, and I told him that we are coming out with a position statement. Yesterday morning, director told me that this is a time that we should integrate palliative care in the COVID-19 patients also. And in the evening, I have told him to Dr. Paul that we are coming out with a position statement, and it is going to help you in making the guidelines for the country. And you know, government of India is doing very fantastic job in these days, that they are because the status of guidelines, and hopefully there will be a provision of. Thank you very much. I don't know what else to say, and I am ready to take any questions. And thank you for helping me to prepare this position statement for IJPC. Gayatri, Nandini, Anuja, Arun, Dr. Stanley, Dr. Nagesh. I think many people were there, so I have not written their names, but definitely the whole community in India, they have helped to come out with this position statement, and it's definitely going to be helpful for the Ministry of Health and Family Welfare. Also, I am really thankful, Gayatri, because today is the last day, so I will take one more minute. Gayatri, Megan, for coming out with this eco platform. I think it was so fantastic. We started with 9 weeks before, and today we are finishing, but this was such huge amount of information we have given to almost 60-70 participants. I can see that every time there are 60 to 70 participants, and they got a lot of information. So thank you very much.
Thank you, Dr. Sushma. I think today Indian Association of Palliative Care is in a very powerful position, thanks to your leadership, and we will bring that change in our country. Thank you very much. I want to really thank all our invited speakers, Dr. Eric Crocker, Dr. Puri, Dr. Sangamitra, Dr. Anuja, for wonderful, I know, very moving and wonderful sharing of experience. I also want to tell you that we have all the resources which we have done, we had 9 series, and the very useful resources shared by each expert. It is there on the IAPC website. This is the link, and this is how it looks like. So when you click on each of the each session, you'll get the relevant resources. Thank you very much. I want to thank Nisha for uploading all this on the website. And there's also YouTube link to all this. You can just go to this. There's a Google Drive. You get all the information and the YouTube link to all the sessions which we had so far. And with that note, and this is the YouTube link, and you can just get all the sessions, all the very useful sessions by all the experts. With that note, I hand over to Dr. Spandana to wind up.
Thank you. I just want to say at the end of our series that we thank all the speakers, and we had some excellent facilitators, very senior facilitators who have moderated all the sessions. And above all, thank you everyone for joining these early morning sessions. I know it's not easy. I know it's not easy when we extend it by more than half an hour, but thank you so much. And thank you everyone for joining. And we will share a feedback link. I know it's quite late, but your feedback always helps us to improve our academics and arrange better sessions. So kindly share your feedback.